Let me ask you something uncomfortable. If your doctor looked at you right now and said, based on your biology, this is the statistically most likely way your body will begin to fail after 60, would you want to know? Most people say yes. And then they spend the next decade ignoring exactly the information that could prevent it. I am Dr. William Lee, vascular biologist, cancer researcher, and author. And what I have found after years working at the intersection of preventive medicine and molecular biology is remarkable. There is a single piece of biological data that every person in this country has had since birth. It is sitting on a card in a drawer somewhere or on a hospital form from 30 years ago. And it is one of the most underutilized biological indicators we have for predicting the patterns of age-related disease. That indicator is your blood type, not the way diet books use it, not the way wellness influencers talk about it, but the way peer-reviewed epidemiological research spanning hundreds of thousands of patients followed across multiple decades has increasingly demonstrated that your blood type leaves a measurable fingerprint on how your cardiovascular system ages, how your brain responds to pressure, how your immune system behaves under attack, and yes, statistically speaking, what is most likely to be the biological mechanism that brings you down if you do not intervene early. Today, I am going to go through all four blood types, O, A, B, and AB. And for each one, I am going to tell you something that most doctors never communicate in a standard appointment, not because they do not care, but because the appointment ends before this conversation can even begin. I am going to tell you the specific biological vulnerabilities that the research most consistently associates with your blood type, and then the specific interventions, dietary, behavioral, and physiological, that the evidence suggests can meaningfully reduce those vulnerabilities. And I want to be clear about something before we begin. I am not a fatalist. I do not believe that your blood type is your destiny. What I believe, and what the research supports, is that your blood type is a biological signal, a pattern in the data that tells us where your system is most likely to be challenged as it ages, and therefore where targeted prevention produces the highest return on investment. Knowing where the vulnerability is does not condemn you to it. It gives you the opportunity to address it before it addresses you. Let me start with the biology of what blood type actually is, because I think most people understand blood type as a label, a positive, O negative, AB, without understanding what it actually represents at the molecular level and why those molecular differences would have any relationship to disease patterns. Blood type is determined by the presence or absence of specific antigen molecules on the surface of your red blood cells. These antigens are carbohydrate structures attached to proteins on the cell surface, and their specific configuration is determined by genetic variants in a gene called ABO on chromosome 9. People with blood type A have A antigens on their red blood cells, people with type B have B antigens, people with type AB have both, and people with type O have neither, but have a different precursor structure called the H antigen. Now here is what makes this biologically significant beyond blood transfusion compatibility. These antigens are not exclusive to red blood cells. They are expressed on the surface of cells throughout the body, including the endothelial cells lining your blood vessels, the epithelial cells lining your digestive tract and airways, some immune cells, and various other tissue types. This widespread tissue expression means that your blood type antigens are part of the molecular identity of your vascular endothelium, and that the immune system's recognition of these antigens as self versus non-self influences both how the immune system responds to pathogens and how the coagulation system, the clotting system, behaves. Additionally, the ABO gene directly influences the production of several proteins that have specific cardiovascular and metabolic functions. Most significantly, the ABO gene affects the plasma levels of von Willebrand factor, a protein that plays a central role in the clotting cascade and in platelet adhesion to damaged vessel walls. People with blood type O have lower von Willebrand factor levels than people with types A, B, or AB, and this difference has direct and measurable consequences for cardiovascular risk that I will describe in detail. The ABO gene also influences plasma levels of factor VIII, another clotting factor, and appears to affect the inflammatory biology of the vascular endothelium through mechanisms that are still being characterized. This is not speculative. The relationship between blood type and disease pattern has been documented in some of the largest epidemiological datasets in existence. The UK Biobank, which contains genetic and health data from over 500,000 participants, followed prospectively. The Copenhagen Heart Study, the Nurses' Health Study, and numerous other large cohort studies have all found statistically significant associations between ABO blood type and the risk of specific disease categories. These are not small studies with marginal effects. These are population-level associations that have been replicated across independent datasets and across multiple decades of follow-up. Let us begin with blood type O, which is the most common blood type globally and the one with perhaps the most counterintuitive risk profile of the four. If you are blood type O, you have probably heard that your blood type is considered protective against cardiovascular disease, and that is partially true, but it is incomplete in a way that has led many type O individuals to under-monitor certain risks and over-monitor others. Let me give you the complete picture. Blood type O is associated with lower levels of von Willebrand factor and factor VIII compared to types A, B, and AB. This translates to a lower tendency for blood to clot excessively, and this reduced coagulability is the mechanism behind the lower risk of venous thromboembolism that has been consistently observed in type O individuals. A meta-analysis published in the Journal of Thrombosis and Hemostasis found that non-O blood types had approximately twice the risk of venous thrombosis compared to type O after controlling for other risk factors. This is a substantial and well-replicated finding. If you are type O, your blood does not clot as readily, and this genuinely reduces your risk of conditions like deep vein thrombosis and pulmonary embolism. But here is what most people do not know. The same biology that reduces clotting risk in type O individuals creates a different vulnerability that is less discussed, but clinically equally significant. Lower von Willebrand factor in type O individuals means that when the vascular endothelium is damaged, the repair process that normally uses von Willebrand factor to anchor platelets at the site of damage is less efficient. This reduced vascular repair efficiency, combined with the fact that type O individuals tend to have higher rates of peptic ulcer disease due to a greater susceptibility to Helicobacter pylori infection, creates a pattern where the tissues most vulnerable to O's biology are the mucosal surfaces of the gastrointestinal tract and the small vessel endothelium. A study published in the American Journal of Gastroenterology found that type O individuals had significantly higher rates of duodenal and gastric ulcer compared to other blood types, and that this association was independent of H. pylori status. The type O antigen appears to create a surface that H. pylori adheres to more readily, and the lower von Willebrand factor reduces the efficiency of mucosal repair after that damage. For type O individuals, the gastrointestinal tract is the vulnerability that deserves most vigilance, not the cardiovascular system. The second, and for longevity arguably the most important, risk associated with blood type O is thyroid disease. A series of studies spanning several decades has found that type O individuals have a significantly higher prevalence of autoimmune thyroid conditions, specifically Hashimoto's thyroiditis and to a lesser extent Graves' disease compared to other blood types. A study published in the European Journal of Endocrinology that examined thyroid antibody patterns across blood types in over 8,000 individuals found that type O individuals had approximately 30% higher rates of anti-thyroid antibody positivity than types A and B. And subclinical hypothyroidism, the state where the thyroid is functionally declining but not yet producing obvious symptoms, is one of the most undertreated conditions in adults over 60 and one with cascading consequences for cardiovascular function, metabolic rate, cholesterol management, cognitive clarity, and energy levels. For type O individuals, my specific recommendations center on several priorities: regular H. pylori testing and treatment if positive, at least every 5 years after 50. Annual thyroid panel including TSH, free T4, and thyroid antibodies rather than just TSH alone, which misses the early stages of autoimmune thyroid disease. A dietary pattern rich in anti-inflammatory compounds that support gut mucosal integrity, specifically the polyphenols found in dark berries, olive oil, and fermented vegetables that support the gut microbiome and reduce the H. pylori favorable environment. And monitoring for signs of subclinical gastrointestinal bleeding, which is more relevant for type O than for other blood types given the combination of greater mucosal vulnerability and reduced clotting efficiency. Now let us move to blood type A, and I want to be precise here because type A has the most extensively studied cardiovascular risk profile of all 4 blood types, and the research has produced findings that are both sobering and actionable. Blood type A is associated with higher plasma levels of von Willebrand factor and factor VIII compared to type O. This higher coagulability is the mechanism behind the elevated risk of arterial thrombosis and ischemic cardiovascular events that has been documented across multiple large cohort studies. A study published in the European Heart Journal that analyzed data from the Copenhagen General Population Study, which followed over 100,000 individuals for more than 20 years, found that non-O blood types, particularly type A, had significantly higher risk of ischemic heart disease and ischemic stroke compared to type O. The hazard ratio for ischemic heart disease in type A compared to type O was approximately 1.20, meaning a 20% higher risk after controlling for traditional cardiovascular risk factors. But the cardiovascular risk of type A is not simply about coagulability. It is also about a specific pattern of response to psychological stress and chronic cortisol elevation that appears to be more pronounced in type A individuals. Multiple studies have found that type A individuals show greater sympathetic nervous system reactivity, measured by heart rate and blood pressure response to standardized stress challenges, than other blood types. This exaggerated stress response has consequences for cardiovascular aging because chronic sympathetic hyperactivity promotes arterial stiffening, elevates baseline blood pressure, promotes platelet aggregation and the coagulability that is already higher in type A, and drives the accumulation of visceral fat that is itself a major cardiovascular risk factor. There is also a specific interaction between blood type A and the risk of stomach cancer that has been documented consistently since the 1950s, and that was one of the earliest established blood type disease associations in medicine. Type A individuals have approximately 20% higher risk of stomach cancer compared to other blood types. The mechanism is not fully understood but appears to involve differences in the immune response to H. pylori infection and to nitrosamine compounds in the gastric environment in type A individuals. The third major vulnerability of blood type A is cognitive decline under chronic stress. A study published in Neurology found that type A individuals with high allostatic load, the cumulative biological wear of chronic stress, showed accelerated cognitive aging compared to other blood types with equivalent allostatic loads. The exaggerated cortisol response of type A appears to have particular relevance for hippocampal health, as cortisol excess is one of the most potent accelerators of hippocampal cell loss and the episodic memory decline associated with it. For type A individuals, my specific recommendations are extensive and prioritized around cardiovascular and stress management. The dietary pattern most protective for type A cardiovascular risk is one that is explicitly antithrombotic and anti-inflammatory. This means maximizing omega-3 fatty acid intake from fatty fish, walnuts, and flaxseed to counterbalance the higher coagulability. Consistently consuming foods rich in vitamin E and polyphenols that reduce platelet aggregation and protect LDL from oxidation, particularly dark berries, extra virgin olive oil, and dark chocolate, and minimizing the dietary drivers of sympathetic activation, specifically refined carbohydrates and sugars that promote insulin resistance and the chronic cortisol elevation that is especially harmful in type A's biological context. For stress management, type A individuals should prioritize this not as a lifestyle preference, but as a medical intervention. The research consistently shows that the health consequences of chronic stress are amplified in type A biology, meaning that the same level of psychological stress burden produces greater physiological damage in type A than in other blood types. Specific practices with the strongest evidence for reducing cardiovascular risk through sympathetic downregulation in type A individuals include regular moderate-intensity aerobic exercise, which reduces both baseline sympathetic tone and reactive cortisol responses, and mindfulness-based stress reduction, which has demonstrated specific reductions in von Willebrand factor levels in multiple clinical studies of individuals with elevated cardiovascular risk. Blood pressure monitoring is especially important for type A adults over 50. Given the combination of higher coagulability, higher stress reactivity, and elevated gastric cancer risk, the type A over 50 screening protocol should include annual cardiovascular risk assessment, including von Willebrand factor if available, regular endoscopic screening if there is any family history of gastric cancer, annual fasting glucose and insulin to detect insulin resistance early, and cognitive function baseline testing every 2 to 3 years after 60. Now let us discuss blood type B. And I want to begin by addressing something that the popular blood type diet literature has created regarding type B that is not well supported by the epidemiological research, which is the idea that type B is some kind of biological middle ground or hybrid between A and O. The actual risk profile of type B is distinct and in some ways unique, with specific vulnerabilities that differ meaningfully from both A and O. The most consistently documented specific risk associated with blood type B is pancreatic cancer. A landmark study published in the Journal of the National Cancer Institute that analyzed data from over 107,000 individuals found that people with blood type B had approximately 59% higher risk of pancreatic cancer compared to type O. This is one of the strongest blood type cancer associations documented in the epidemiological literature, and it appears to be related to the interaction between the B antigen expressed on pancreatic ductal cells and the local immune environment that influences susceptibility to transformation and to early immune detection of malignant change. Pancreatic cancer is particularly significant from a longevity perspective because it is one of the most lethal cancers when diagnosed at advanced stages, with a 5-year survival rate below 10% for late-stage disease, but with dramatically better outcomes when detected early. For type B individuals, this risk profile makes pancreatic cancer vigilance the single most important preventive priority that most doctors never specifically communicate. The risk factors for pancreatic cancer that type B individuals can actively modify include smoking, which approximately doubles pancreatic cancer risk in everyone, but has an even greater proportional impact in type B given their elevated baseline risk. Chronic pancreatitis, which is a precursor condition that benefits from dietary intervention, specifically reducing alcohol and saturated fat, and metabolic syndrome, which has a particularly strong association with pancreatic cancer risk in type B individuals based on the interaction between the B antigen and insulin receptor expression in pancreatic tissue. The second vulnerability of type B that is less recognized but increasingly documented is a specific pattern of immune dysregulation that makes type B individuals more susceptible to certain viral and bacterial infections. The B antigen appears to create a less favorable binding environment for certain pathogens, while paradoxically creating a more favorable environment for others. Type B individuals have documented higher susceptibility to urinary tract infections caused by E. coli strains that express lectins that bind selectively to B antigens, and to certain respiratory infections, including some strains of influenza that use B antigen-related structures as entry points. For longevity specifically, this immune pattern means that type B individuals should be especially rigorous about vaccination compliance, should support immune function through consistent sleep of adequate quality, vitamin D sufficiency, and zinc adequacy, and should be particularly vigilant about urinary tract health, which if chronically undertreated can progress to kidney damage that accelerates cardiovascular aging through its effects on blood pressure regulation. The dietary recommendation for type B that has the strongest evidence base is one that prioritizes supporting pancreatic health. This specifically means limiting processed red meat, which produces N-nitroso compounds during digestion that are particularly carcinogenic to pancreatic tissue. Maximizing fruits and vegetables with documented anti-pancreatic cancer activity, especially green leafy vegetables, cruciferous vegetables, and citrus, whose flavonoids have demonstrated specific anti-proliferative activity against pancreatic cancer cell lines, and supporting the gut microbiome with prebiotic fibers and fermented foods that reduce the systemic inflammation that the research identifies as one of the mediators of type B's elevated pancreatic cancer risk. Now let us discuss blood type AB. And blood type AB presents, in my view, the most complex and clinically nuanced risk profile of the four types, because AB combines aspects of both the A and B antigen biology in a way that creates a unique pattern of vulnerabilities that is not simply additive of the risks of A and B separately. Blood type AB is the rarest of the four main blood types, present in approximately 4% of the population. And the epidemiological literature on AB, partly because of this rarity, has fewer large-scale prospective studies than A or O. But the studies that do exist paint a consistent picture of a blood type with genuinely distinct risk patterns. The most significant and most consistently documented vulnerability of blood type AB is cognitive decline and dementia risk. A study published in Neurology, one of the most authoritative journals in neurology, found that blood type AB was associated with an 82% higher risk of cognitive problems and memory difficulty compared to other blood types after controlling for age, sex, race, education, and cardiovascular risk factors. The size of this association is striking, and the proposed mechanism involves several converging factors. First, AB blood type is associated with the highest levels of factor VIII of all the blood types, which contributes to hypercoagulability in the cerebral microvasculature. Cerebral small vessel disease, which is driven in part by chronic microthrombi in the small vessels of the brain, is one of the primary pathological substrates of vascular cognitive impairment, and the high factor VIII of type AB creates a procoagulant environment in the brain's microcirculation that promotes this type of subtle, cumulative vascular damage. Second, type AB combines the stress reactivity of the A component with the immune peculiarities of the B component in a way that creates an elevated baseline inflammatory tone in the central nervous system that is particularly relevant for neurodegeneration. Chronic neuroinflammation is one of the primary drivers of Alzheimer's pathology, and type AB's combined antigen expression pattern appears to create a neuroimmune environment that is more prone to sustained inflammatory activation. Third, type AB is associated with higher rates of what researchers call cardiometabolic clustering, meaning the tendency for cardiovascular risk factors including hypertension, insulin resistance, elevated triglycerides, and elevated homocysteine to co-occur in the same individuals. Each of these factors independently increases dementia risk, and their clustering in type AB individuals creates a compounded cognitive risk that exceeds any individual factor. For type AB individuals, the most impactful preventive strategy for cognitive longevity specifically centers on aggressive management of vascular risk factors. Blood pressure control in the optimal range rather than simply below the hypertensive threshold, which means aiming for systolic pressures below 120 rather than simply below 140. Homocysteine monitoring and management through B vitamin adequacy, specifically folate, B6, and B12, whose deficiency is one of the most treatable and most often overlooked contributors to elevated homocysteine and vascular cognitive impairment. Omega-3 fatty acids from fatty fish 3 to 4 times per week, whose DHA content is specifically neuroprotective through its role in maintaining neuronal membrane fluidity and its anti-inflammatory effects in the brain, and cognitive engagement. The research on neuroplasticity and cognitive reserve consistently shows that individuals who maintain high levels of cognitive challenge through education, novel learning, social engagement, and mentally demanding work or hobbies show slower cognitive decline regardless of their biological risk factors. For type AB individuals, investing in cognitive reserve is a genuinely life-extending strategy in the most literal sense. Now, I want to spend the final portion of this video addressing what I consider the most important practical implication of everything I have shared, which is the concept of blood type-informed personalized prevention. The traditional medical model of disease prevention is population-based. We identify risk factors that are harmful on average across all individuals, and we recommend interventions that reduce those risks in the average person. This approach has produced enormous public health benefits, but it is inherently imprecise when applied to individuals because it treats everyone as equivalent when biologically they are not. Your blood type is one of the earliest and most stable biological signals that differentiates your individual risk profile from the population average. It does not override other risk factors. It does not make some risks irrelevant. But it provides a layer of biological specificity that can guide you toward the preventive priorities where your own biology is most vulnerable and where prevention produces the highest return. If you are type O, this means prioritizing gastrointestinal health surveillance and thyroid monitoring rather than being lulled by your lower cardiovascular thrombotic risk into thinking your whole biological system is lower risk. If you are type A, it means treating stress management as a medical intervention with measurable cardiovascular consequences rather than a lifestyle luxury, and being especially rigorous about stomach cancer screening if there is any family history. If you are type B, it means taking pancreatic health seriously through the specific dietary and behavioral modifications I described, and being especially rigorous about immune support and vaccination. And if you are type AB, it means prioritizing the aggressive vascular risk factor management that your cognitive longevity depends on and investing actively in cognitive reserve. What blood type-informed prevention is not is a license to ignore the universal foundations of healthy aging that benefit everyone regardless of blood type. Regular moderate intensity exercise, quality sleep in adequate duration, an anti-inflammatory dietary pattern rich in vegetables, fruits, legumes, and omega-3 fatty acids, maintenance of a healthy body weight, not smoking, and appropriate alcohol minimization are protective across all blood types. Your blood type tells you where to pay additional targeted attention, not where to substitute that attention for the universal fundamentals. I want to be explicit about one more thing before I close. The research I have described today is epidemiological in nature. It describes statistical associations observed across large populations over long time periods. It does not determine individual outcomes. A type A individual can live to 95 without cardiovascular disease. A type O individual can develop clotting disorders. A type B individual can never develop pancreatic cancer. Statistics describe populations, not individuals. What they tell us is where the probability-weighted vulnerabilities lie, and therefore where prevention is most likely to matter most for your particular biological context. The most dangerous response to this information is fatalism. The second most dangerous is ignoring it. The appropriate response is to use it as a tool for targeted prevention, to have conversations with your doctor that are informed by your blood type biology, and to make the lifestyle and monitoring choices that are most specifically aligned with the biological system where your risk is highest. Your blood type is not a sentence, it is a signal. One of the most stable, most accessible, and most underused signals in preventive medicine. You have had it since birth. You have probably had the data sitting in a drawer for years, and now you have a framework for using it. I am Dr. William Lee. If this video gave you something valuable today, please share it with people in your life who want to understand their own biology at a deeper level. Subscribe to this channel for more evidence-based medical information that goes beyond the standard conversation, and leave me a comment below. Tell me your blood type and tell me if what I described for your type matched anything you have already experienced or observed in your own health history. Understanding your biology is the beginning of taking control of it, and that control starts with knowing where to look.